right, so welcome to another episode with On the Mic with Ed. You are here with myself, Maria Ortiz, and co-host Dr. Zoe Ross-Nash. We also have Devin Crochet with us today, a registered dietitian, and she is joining us so that we can have a very hopefully impactful conversation about higher level of care. That's a topic that comes up a lot in eating disorder work, so we just felt like we could not miss the opportunity to discuss this material, and we're very grateful to have Devin with us today. So I will let Zoe thank our advertisers.
Yeah, thank you again for joining us, Devin. And also a special thank you to our advertisers, Alsana. Alsana has physical locations in both California and Alabama, and then they have virtual IOP options as well. And they even have a team program. So might be a great place to look into if you're looking for those sort of services. And which is great because we are talking about higher level of care today. So Devin, let's just jump in. Can you actually describe for the listeners the different types of level of care for eating disorder treatment? Because it can get confusing.
Absolutely. Whenever I bring up the term higher level of care with a client, whenever we're broaching that topic, I think it is really important to delineate the different levels of care. What does that mean? So I will start at the highest level of care and maybe just work our way down. So the highest level of care would be inpatient, right? So that would be you're inpatient in a hospital. And so in that circumstance, and again, I'll lean on you two to kind of rope in and just add your piece of things. But typically you're getting plated meals. Typically you are required to complete those meals. There are circumstances under which if you're unable to complete your meals for whatever reason, there may be what we call enteral or like tube feedings you may have heard. So that's kind of what that inpatient level of care is. And that is for the people who are absolutely at the most risk. So potentially life-threatening circumstances under their eating disorder. And again, we're going to be talking about, mainly the eating disorder side of things. That's obviously my kind of like scope of practice. But there are other reasons you might need to be inpatient for mental health reasons as well. But this is specific to those eating disorders. So again, usually someone's life is in danger. So as a dietitian, I'm looking at, are there potential electrolyte imbalances, reasons that someone has been not nourishing well that may actually put their life in danger. So that's the highest level is inpatient. Next, we have residential. So what's the difference between inpatient and residential? Well, residential, you're not usually in a hospital. It's usually more of like a home setting, but you are staying overnight, usually for a period of weeks. We usually try to get people out of that inpatient, that very critical level of care, and into that residential as quickly as possible, just because we don't want you laying up in a hospital for weeks on end. That wouldn't be fun, right? So residential is you're usually in a home setting, usually in a group setting. There's other people in that residential care facility with you, and you're doing all types of things. You're usually completing all meals and snacks within the facility, right? And then you're usually having like group therapy, individual therapy, meeting with your practitioners. So you are in that facility 24/7. The next level would be what we call PHP, or partial hospitalization program. Other programs have called it like day program. You'll sometimes hear that terminology as well. But PHP, it's usually around like 5 days a week, and you're usually spending kind of like a normal work day or school day, about 8 hours or so. And most of the time we complete about 2 meals and maybe a snack at PHP. And that's similar to the residential, except for the fact that you go home and you usually complete at least 1 meal a day at home. A lot of times that's dinner, or, maybe it's breakfast, but again, usually 2 meals a day is happening at PHP. And similar to residential, you'll probably be in group programs. Maybe there's like art therapy, things like that, or different types of either group and individual therapies. You're being medically monitored there the same way you would be in a residential. But usually folks are a little bit more stable when we send them to PHP. And then the next step below that, there's so many steps, is IOP, or intensive outpatient program. That's usually around 3 days a week. Either it's usually 3 days a week for a few hours during the day, maybe like a half day, or it might be in the evening, so like a 3 to 7 p.m. type situation. And that's usually 1 meal that you're completing there. And so again, you'll have a lot of the same elements of therapy and care that you would get at PHP, right? You're probably meeting with a dietitian at all of these levels. And certainly you're getting that therapy care and usually some group stuff as well. And then below that is kind of where I exist on the private practice outpatient level. And outpatient is usually when someone is really participating in their own care and recovery, but they still do need some consistent support and help, especially in the realm of nutrition. So they're oftentimes following a meal plan. They may be following the meal plan that they kind of transitioned out of their higher level of care from into. Like I try to keep people's meal plan like pretty consistent to what they were experiencing in their higher levels of care. But they're the ones who are actually putting the meals together most of the time. If they're a minor, if they're a child, they may have parents very involved in that process, or maybe even, planning and plating the meals for them. I know you guys can speak a lot more to that. But that's that level of outpatient care where I exist. And so those are the different levels. I hope that wasn't too wordy. But clearly you can see that there are different levels for different people, and you might not necessarily start in inpatient and work your way all the way down through. You may start in residential or PHP, or you may just live in outpatient. You may never need a higher level of care. So eating disorders really vary so much in their severity and their duration. So I can't really say for sure how long you're going to be in each of these stages. It really just depends on your own recovery path.
I actually appreciate your disclaimer of like hoping that wasn't too wordy because there's no other way to explain this. And I think it's a big reason why people have a lot of uncertainty or fears or anxiety is because they ask the question, what does this look like? And we all like take this breath and then we kind of share. So I think that's actually just a huge reason too that a lot of times people are kind of intimidated by this topic because it's like which one's which again and which order do I go in? And so I actually really appreciate that kind of the delineation in the order so that people can hear that and understand. And there's nuances to all of the above, which just make it all even more complicated, right? A residential center at one place might have different rules than another. Um, but I really appreciate kind of your explanation with that. So you brought up for like inpatient, if you notice things like electrolytes. What are some presentations that you see in an outpatient setting that would also illustrate, I think that we need more support here than outside of that private practice outpatient setting?
Yeah, absolutely. If I am concerned about like again like other maybe mental health concerns like suicidal ideation, this person really feels like they might be a danger to themselves. That's always a circumstance under which I'm communicating with the therapist. Hopefully there's a therapist on board at that point and we're saying like, hey, I think this person really needs that highest level of care. But from a medical standpoint, I look at things like their heart rate. If I see very low heart rate, which is unfortunately common, particularly in restrictive types of eating disorders, that might be a circumstance where I would feel most comfortable for their safety, for them to be in an inpatient setting so that they can be specifically like have a cardiac monitor and have someone looking at that regularly. Another thing I may see is if there is like severe edema. Sometimes that's something I will see if especially if there has been a period of very intense restriction and then starting to reincorporate foods. That edema, so edema for those who are not in the medical community is mainly like swelling. And so a lot of times I will see that in like the feet and ankles. And that is a sign to me that there may be an electrolyte imbalance, right? Because electrolytes help keep the fluid where it's supposed to be. So if it's in what we call those interstitial spaces, so not in the blood, not in, the places we would normally see it, it can show up as that lower extremity swelling. And that is always a big concern to me. If I have concern for maybe it's called jaundice, which is like the yellowing of skin or eyes, that might be a sign that there may be some liver damage at play. And that would be a good time to maybe consider that inpatient level of care. But I'm curious to know what you guys think.
Yeah, the American Psychological Association actually has a chart that goes through all of the recommendations for what you're seeing to send them to whatever level of care they're needing. So if you are a clinician or a family member or even a person that's wondering what they might need themselves, you can just Google American Psychological Association levels of care, eating disorders. And that will give you some pretty concrete ways to navigate it. And obviously, every situation is different, and accessibility really determines whether or not you can go to higher levels of care. Insurance also impacts these sorts of things. So it's really what makes it difficult. And the language also, like HLOC. There's so many acronyms: IOP, intensive outpatient, PHP, partial hospitalization, which is why I really appreciated you translating that language. There's also other ideas of like step up or step down. So step up means you're going to a higher level of care or going up in treatment, where stepping down means you're going to a lower level, less intense treatment. So there's so much language around this, and I'm really glad that we're getting to demystify it.
I think some of those things too, I mean, that criteria is awesome that's listed, yeah, with APA, and it can be a really good frame. And I also think there's so many other nuanced kind of topics. So I might have a couple of clients that are presenting highly similar, honestly, whether it's in their medical background or experiences or even in their therapeutic presentation. Sometimes it comes down to what level of progress are we making outpatient, right? So even if two clients come in highly similar, obviously we're going to approach them with a unique treatment style for each. But we're looking, what level of progress are we getting? Are we achieving any weight restoration? Is our thoughts around food and body coming down? Are we able to gain, engage with a more of an autonomous life? That's a big pillar that I look at is sometimes it's not like, do we have to? I really try to take away the have and would this be really beneficial for myself and my recovery? So a lot of times too, it might look like support in the home. Are people being really, really well supported and people are helping them with their accountability? They've got this system kind of around them. And for the people that might not have that, sometimes they really might benefit from sitting down at a table with six other people that feel the exact same way at this meal, and it might make them feel really seen and supported. So I really try to just destigmatize what is the have to, what did I, sometimes clients will really verbalize to me, I can't believe I got to this place. And it really comes down to just what is going to benefit us, what is going to support us in the long run, what levels of support are we needing. So sometimes I even try to rechange the language from level of care to level of support, and sometimes I found that to be a little bit more palatable.
Absolutely, absolutely. And I think it can be tricky because a lot of my clients, when we do have that higher level of care discussion, they almost feel like they've failed their dietitian or they've failed their team or they've failed themselves. And that is really, I try to really shift that perspective. It is not a failure on yours by any stretch of the imagination. This is really just like a higher level of support. And in some ways, it can feel very like a big interruption in their life. And sometimes that's actually what's helpful, right? If we're kind of in this environment where we've gotten sick, we've gotten ill, we're struggling with this eating disorder, sometimes it's helpful to kind of step out of that environment to get to zoom out. And that's, I think, one of the biggest benefits of higher level of care is that you get a little bit of a pattern interrupt and you get that group support around people that maybe really understand what you're going through much more than anyone else at home.
Yeah. I've never heard a client say, I wish I waited to get the level of care that they needed. And a lot of it also comes down to your therapist, your dietitian's comfort. So so I'm only virtual. It is very, very hard for me to see very high acuity in terms of anorexia. Whereas if you're able to really be in the room with them and do weigh-ins or blind weigh-ins, and you have more accessibility to that sort of acuity. So it's so contingent on all of these different factors, like Maria had said. But I would like to hear more about the process of even going to higher level of care. What does that look like?
Absolutely. So typically it starts with, me as the dietitian, or perhaps you guys as the mental health providers might reach out and say like, hey, I think, here are a few higher level of care options that I think would be a really good fit for you. My inkling is that you should be at this level of care. This is going to be my recommendation. Again, I'm always coordinating with a therapist or psychiatrist in this realm because I'm very like amenable to their opinions on this. I always see my dietitian side of things. But typically we're scheduling an initial intake assessment with a provider at this higher level of care facility, and they will ask a slew of questions, usually around like an hour or so. And they're asking questions to really sort of gauge where you're at in your recovery. What is your motivation? What kind of behaviors are you exhibiting? Kind of like what's your mental state? So all of those questions will kind of help them guide you in terms of what level of care they deem to be most appropriate. And so that initial intake assessment is one of the most important pieces of that. And then from there, they'll make their recommendation. Sometimes there's a waiting time to get into these programs. Unfortunately, hopefully that's not the case. But when we're talking about higher level of care, I really usually encourage my clients, like, just make the appointment. I know you feel like, oh, I don't know if I need this, but you're better off having the appointment and getting that recommendation, and then you get to decide to do what from there. So that's typically how that works. And again, I would love for you guys to fill in the gaps in terms of what I missed there.
I love that explanation. And I love what you said there of like, and then you get to decide what you want to do. So, a really common thing that sometimes I do in my practice, granted, if it's somebody that we know higher level of care is going to be a necessity in their recovery, that conversation might look different. But for some folks, I might just say, like, hey, make the appointment, do
Mhm.
the intake. That is not accepting a bad. Your insurance is not approved yet. Nothing is committed to. And so sometimes what I'll say to people is there's that waiting period. They might say, fantastic, we're recommending an admission at this level, and we have a bed in 4 weeks. So sometimes what I tell people is that we get the ball rolling, and then I say, if we don't need it, amazing. Sometimes I've seen people really be able to use this as a motivating factor when they realize, whoa, they really did recommend this for me. They get this new level of engagement with their own recovery process outpatient. And I have had before where we maybe have done an intake, they've made a recommendation, and then the client has really been able to lean on the support sources they have. Maybe they picked up their session frequency. But that's a really common way that I share that too, that we don't, it doesn't mean that we're taking it, but if we need it, what I always say is if we need it, I want it to be ready. I don't want us in a month to say, you know what, I'm ready to take this leap. And now we're on a 6 week wait. And honestly, wait lists have been higher than that in the past before too. So I always tell people, if we want it to be ready. We don't want to say I'm ready and then be waiting.
Absolutely, absolutely.
And it's so valid for people to be afraid to make that sort of big jump to higher level of care. So what type of fears do you typically see when you make these recommendations?
Oh my gosh, where do I begin? So the first one is typically like, work or school, like just thinking through the logistics. I think when you share this concern, like, hey, I really think we need to consider a higher level of care here, I see the wheels start turning. And they're usually thinking about all those external logistical factors for how am I going to make this work? So cost is a huge one. Unfortunately, there can be limited coverage for this higher level of treatment. And that is always one of the bigger concerns. Definitely just the pattern interrupt of I'm going to be missing school or I'm going to be missing work. And how is that going to work? Another concern I often hear is what are people going to think, right? If you are all of a sudden missing from your life for a period of weeks, understandably, there may have some questions come up. I had one client who told her classmates that she was going to a basketball camp, like a presidential basketball camp in like some crazy place. So they come up with all different reasons why they're leaving, and I had that conversation with them too, and encouraged them to talk to their therapist about like, hey, how do you want to kind of talk about this with the people in your life? Understandably, there's going to be people that you don't want to share this eating disorder recovery with, that you don't necessarily want to have that level of vulnerability with. And then there are also maybe some people that you need to really think about, but might be a good resource for you in your support. And it also really requires the education of how to support someone. And so I think those are the three big ones. It's like the cost, the like pattern interrupt in work and school, and then what are people going to think, and how am I going to talk about where I'm going? How honest am I going to be about this? Which again, there doesn't need to be any shame about this, but I could understand where someone might not feel comfortable sharing with the entire world their eating disorder while they're in such a sensitive part of their recovery phase.
Yeah, I've also heard when I recommend a higher level of care to clients that they're not sick enough. Oh,
Mhm.
I'm not sick enough for that level of care. And sometimes they engage in behaviors to make them sick enough, or sometimes it keeps them stuck in that same area of recovery or their pathology, so they don't have to really go to a higher level of care. So that's where it gets really sticky, is that not sick enough mentality.
Yeah.
That sick enough piece is part of the pathology of an eating disorder, right? Part of an eating disorder is saying you're not sick enough. And what I always say is it's not going to give you that like stamp of approval and great work. It's going to tell you consistently you're not sick enough. And I think that contributes to the mortality rate associated with eating disorders. And also the media kind of tells people that they're not sick enough. So I can't tell you how many times somebody's presented in my office and I'm immediately like, I have high concern. I'm talking to the dietitian. We are both on the same page with high concern, maybe the medical doctor, high concern. And the client is incredibly confused. And they're like, I don't understand. I don't like look like those girls on the TV or whatever it is. And granted, they very well could have similar attributes, but their ability and insight into their disorder is not allowing them, and or they really don't, and that just doesn't determine the magnitude or severity of what's going on. So I think that there's a lot of confusion there. um, I also I like that Devin brought up the idea of those external factors. Whenever I am discussing eating disorders or giving a lecture, those sort of things, I always include a slide about higher level of care that says there's never a good time. I rarely hear somebody say, now's a perfect time. I can uproot my life. Let's go. It is typically, I have kids, I have dogs, I have school, I have work, all these things. And so what I always tell people is that we're not waiting for a perfect time. It's not going to come. And that's a really nuanced conversation to have because we want to validate the struggles that are there, while also acknowledging these are life-threatening disorders. And it's a really nuanced situation. But you did touch on insurance and like financial coverage. I'd love to hear a little bit more information about how that impacts the higher level of care process.
Absolutely. So I can't tell you how many times I've been in a circumstance where I'm very, very concerned and I would really love someone to be in a higher level of care. Unfortunately, financials really get in the way of that. And so a lot of times the inpatient care or the residential care, higher level of care will go towards a deductible, which is a certain amount of money you need to meet before insurance will kick in and cover something. And depending on how high your deductible is, that can really impact a family's financial circumstances. And so that is a huge, huge barrier to care. And oftentimes people feel way more comfortable just kind of staying at that outpatient level of care where maybe they have their visits covered or maybe they have a copay. So those insurance premiums, those deductibles can really, really get out of hand. And I think this is a big place that we in the healthcare industry really need to advocate for some progress in that regard, because these people really need this level of care. This is not a should, it's a must.
Right. And I feel like we're seeing insurance getting in the way of healthcare across the board. You're hearing of anesthesiologists having to get approval to extend their folks being under during a surgery. So this is not something that's unique to even eating disorders. And that's what makes it so frustrating. But there are opportunities for scholarships. I think, what is it? The Alliance for Eating Disorders offers scholarships for higher level of care. So yes, there are a lot of obstacles to getting to higher level of care, and there are support systems like the Alliance that have systems in place to get people support that they need. Marie, it seems like you're going to say something. Yeah.
Yeah, I think it's too, one, yeah, reaching out for those support options and seeing what they can offer. I mean, these systems and treatment centers are used to working with this. Most people don't go skipping in being like, here's my money to cover this. A lot of times they even like they have people working there where it's their whole role to figure out the financials. So I always tell people that there's somebody, it's their whole job, at least talk to them. Another common concern I see is insurance saying will cover, but not at the recommended treatment level. So
Mm.
maybe I'm in agreement, the dietitian, the medical doctor's in agreement, and the treatment center is all in agreement that the residential level of care would be appropriate for this client. And insurance may come back and say, we will cover PHP. So I think that also sends a signal to the client that they weren't sick enough, too. So as Zoe brought up earlier, sometimes it might keep them kind of stuck, or now they're not getting the level of care they really need, and or they get themselves quote unquote sick enough that now insurance approves. And so that's just another frustrating loop that I kind of see there as well. But finances play a role. We can't pretend that it doesn't, but we also can't. These are lives in a balance.
But in
Absolutely. And I see that during the higher level of treatment care path too, is that when someone is already in their higher level of treatment, and this is where we see a ton of weight bias in terms of the insurance companies, especially, they may say, oh, well, we see this person gaining weight and, they are no longer at what we would consider a unsafe weight. And of course, they're using things like the BMI to assess this, which is completely inappropriate, especially in this circumstance. We know that eating disorders don't just impact people with a certain BMI. That is not how we diagnose eating disorders or the severity of an eating disorder. But we do see a lot of weight bias there. And while someone is going through their higher level of care path, let's say they're in residential or they're in PHP or IOP, and they are showing progress, I will unfortunately sometimes see insurance saying, hey, they're better, we're no longer going to cover this. And they get booted out before they're actually ready to transition. Or like you said, Maria, they will sort of keep themselves sick enough so that they can stay at this level of care because they know that they need that support and they want to be able to stay longer. So that's a really unfortunate element of this, but it's something that we're constantly navigating.
Yeah, I feel like when insurance does not listen to treatment providers, it validates or invalidates that sick enough mentality, and it gets into a really dangerous stance. And in addition to like other obstacles that get people to higher level of care, how would you say proximity intertwines with all of this?
Proximity, you mean in terms of like geographic proximity? Oh my gosh, it's huge. It's a huge problem. I will say, especially where I exist here in Western Pennsylvania in the Pittsburgh area, we sort of have a monopoly of like one higher level of care provider, so that we don't really have a ton of options. And so if that, one provider doesn't accept your insurance, or, you just don't really vibe with their treatment style, you're really sort of stuck in a place where it's, okay, I'm sending maybe, a younger kid out of state, or you're sending them hours away where, the parents don't have easy accessibility to be able to visit them on the cadence that they would like. And so depending on where you're living, if you're in a rural area or even in a metropolitan area like Pittsburgh, you're really limited in terms of what is accessible for the higher level of care. And then when we think about stepping down from residential to IOP or PHP, now it's possible that we have to switch treatment centers because the one that we sent them to doesn't have an outpatient location that's close to where we live. And I know I'm telling a story as you're nodding your heads. I'm like, I know you've been in the same situation with patients, and so that is a huge barrier as well.
Yeah, I worked at a inpatient and residential treatment center in Florida, and I remember I had a 14-year-old that was there, and she was from California. So I'm sorry, just again, early in the morning, can't talk. This 14-year-old was traveling across the country for the first time by herself to do one of the hardest things that she's ever done, just because treatment was not accessible where she lived, and this was the only place that accepted her insurance or her pathology.
Yeah.
And this, I think, is an issue that like needs to be worked on, but I also understand like the nuances that go into this. This isn't an easy feat to just, bring up high quality treatment centers, but I can think of in my own area, I can list off like 5 detox facilities like within a really close radius. We actually don't have any eating disorder higher level of care within about 2 hours. So you have to drive 2 to 2.5 hours no matter what. That's the closest that you're getting. And again, kind of like what Devin brought up, that's if like you align with that treatment center, that's if your insurance accepts. So there's been a lot of times, absolutely, that people are flying out of state and then they're flying from the residential center to a PHP location and they're flying back. So I think that that's really, really challenging. And I think proximity, at least when I'm working with kiddos and families, I think that's a huge barrier that I think there are many clients I would have had that would have been more willing to engage with their kiddo at a higher level of care if they could access their kid in less than 2.5 hours. Especially dependent on age. I really don't blame them for not wanting to just kind of drive away from their child at a location they just learned about as well.
Yeah, I've had to send patients as young as 8 to places as far as Colorado, and I'm in Pittsburgh. So imagine, sending your 8-year-old somewhere that far. It's not an easy decision to make, but you're totally right. That is a huge barrier to getting the buy-in from especially parents.
When NITA had their hotline, I used to volunteer for them and help people get accessible treatment. And especially in these like very rural states, there wouldn't be anything anywhere close to them, even for like IOP. So it's really quite sad, and I don't even know a solution to this.
Mhm. Yeah.
It kind of makes me think of um, too, it's like you're sending them away and also like how long are they going to be there? So that's also what I'm navigating with family members is they're like, well, how long are they going to be in this other state or something of that nature? How do you navigate those questions?
Oh my gosh, that's one of those questions that's like you said, deep breath and saying like it really depends. It really depends. And so usually I'm really just reiterating that like this is um the most sure path towards recovery in this circumstance. And I wouldn't be recommending it unless I really believed that and have seen it to be true in so many of my clients. And so I kind of have that conversation. It's like, hey, I can't promise you that it's going to be 4 weeks or 6 weeks or I have no clue, right? So, but it's typically a matter of weeks. And the quicker we can get them to a safer place, the quicker they can come home. And so, this is usually like a huge motivator for the family to really have some buy in and say, like, okay, we're going all in on this.
I just want to send some extra love to parents who are making this decision. It is an incredibly hard decision, and your treatment providers are not taking this lightly. And we also know how difficult it is for you to make this decision. So, just sending you all so much love and care and compassion.
Yeah, absolutely.
I appreciate you saying that too, because sometimes, and I don't know if this is always the case, but sometimes I almost get the feel that clients think that this is an easy decision for us and that we're just like, oh, they just need more support. This is really hard and something that we often have had multiple meetings about with the treatment team, multiple meetings with the family. We have assessed our case notes and our case conceptualization and our interventions, and we've really gone we need to make a hard decision here, and sometimes that does fall on us that we need to be making it, but it is in fact that a hard decision. So Devin, I use very similar language where I say I would not recommend this unless this was highly necessary and that I worried that we're basically doing harm without it. I make it very, very clear that this is not something that I just on the whim want to do. Another thing that I like to say too is that I could work at a higher level of care. I work in outpatient because I really value outpatient work. So I always tell people, clearly I believe in this process. Clearly I value this work, and yet I still don't think that it's enough for what we need to do right now.
Yeah, as a provider, I would love to hear what your experience is like just on emotional level with making that recommendation, because I always find that to be so hard. And I've had clients respond with like, don't give up on me. And it's like, I am by no means giving up. This is me being like fully invested in you. But I could see how it feels that way, or me throwing my hands up and saying like, oh, this is too complicated for me. It's really not that. It's that I really think that this would be the best path for you. And I don't feel like I would be doing you a service by allowing you to stay at this level of care, and allowing you to continue down this path of maybe being stalled in your recovery, or maybe even getting worse.
Well, something I say about being an outpatient provider is knowing when to ask for help and knowing when I need help. So I am very aware of my boundaries of what I have access to and capabilities of in an outpatient setting. And so I let them know part of this work is knowing when to send. And I guess from the emotional lens, I too will sometimes receive those sort of things like, oh, yeah, you're giving up or something. And what I tell people is, no, I'm so invested in your recovery. That's why I'm doing this. One, I don't give up on any of my clients. I love to hold the hope until they can hold it too. But I really just let them know, no, I'm invested in your future life. And I always say you're not required to do this, but I say I love seeing years down the road an update that somebody got married, somebody went to college. I said, that's why I'm recommending this. And when it's really hard, I just go there with them. I say, this is intently challenging. And I really just kind of level with them there that I can't even imagine how you must be feeling right now. And so sometimes I think that if you can just kind of join them in that and not be dismissive of all of the things that are going on. I think for my own emotions, where I have to actually even check in with myself as a clinician, is when I'm sending somebody maybe like over a holiday. Those things really are hard for me because I'm well aware their entire family's getting together and now they're away in another state. So I think acknowledging our own emotions that we're feeling, it only shows us a snippet of where they are at. And if we can kind of level, sometimes I even self-disclose that. Like I'm not thrilled either that you're going to be missing your favorite holiday with your family. Yet I'm still making the recommendation. I almost think if you can level with it, it even proves your reasoning even more.
Yeah.
Yeah, the holiday stuff got me too. And birthdays as well, and parent birthdays too, anniversaries. As you said, there's really no right time to go. And I try to normalize that to my clients. Like, this is likely going to be the hardest thing that you've ever done. And I am here supporting you through it. I will be here when you're back. And I wouldn't make this recommendation unless I truly, truly believed it was for you. And this is when I also provide some psychoeducation, just knowing what that higher level of care looks like. So let's just say we are sending it over holidays. Like, hey, we as a treatment team, we used to make ornaments together, or we had a special dinner that was catered around whatever holiday it was. And it helps give a little bit more understanding of, okay, this is what life would look like, which actually goes into an important question of what does a typical day of higher level of care even look like?
Yeah, absolutely. Well, of course, it depends on what level of care, but let's just say it's like maybe like a residential, or like a PHP, partial hospitalization, where you're there for pretty much the whole day. So usually it would start with like breakfast, right? There's some kind of like meal. And usually there is sort of like a set time, because one eating disorder behavior we will see is folks stretching out meals for a super long period of time. So there is a time limit on breakfast, and that's not meant to be overwhelming or stressful. It's really to just kind of help reestablish a normal eating pattern. And so there will always be usually a few members of the treatment care team. So usually the dietitian is there, usually there's a few therapists, or other support staff there, sitting with you and enjoying the meal with you. And one thing about eating disorders is that not everyone is sort of triggered by the same foods. Not every person has the same fear foods. And so one meal that might be a walk in the park to one person might be really overwhelming for another. And so we will see, different types of responses to whatever meal is offered at that meal or that day, especially when it comes to holidays. Holidays can be a big challenge for folks with eating disorders, especially some of those holiday foods can feel like a big challenge. And so I actually think that's one of the benefits, like one of the few benefits to being in higher level of care during a holiday, is that you get some skills for navigating those types of foods and those types of meals and situations, even if it's not a perfect replica of what you would experience at home. But yeah, so it usually starts with that breakfast meal. Again, there's usually like sort of like a time constraint of some sort. And then a lot of times they'll have a group session afterwards. So maybe we are processing that meal and kind of talking about what's coming up for us. A lot of times there will be appointments kind of sprinkled throughout the day. So this isn't usually like the same time for everyone, but usually at different points in the day, a single patient will be pulled out for meeting with their therapist, meeting with their dietitian, their psychiatrist. So one or two people might be missing from your group sessions because they're at these individual appointments. A lot of times there are daily vitals that are checked. So they will probably do some kind of blind weight check. They may take things like blood pressure and other just like vital signs to make sure that we're medically stable. That's part of this higher level of care environment, right? That's part of what it offers, is that closer medical monitoring. So that's usually part of the day. A lot of times there may be maybe like some fresh air time. There may be some treatment centers that offer like some really gentle movement, like stretching, breathing exercises, yoga. I love getting to engage the body in that way during recovery as well, because I know so many clients that really get a lot of value from movement and exercise are very limited in that capacity when they're at a higher level of care for good reason. And so those types of elements I find to be really helpful. A lot of times there's things like art therapy or music therapy. Again, like there's group, there's individual. And so it kind of depends on the treatment center, what they offer. And, every day might look a little bit different, but that's the general flow of things. There's meal times, there's group, there's individual, there's vital signs that are checked at some point in the day. And then there's usually some kind of like fun art therapy or music therapy or other element like that.
Yeah. I remember when I was working at higher level of care, it kind of felt like a bubble. And that bubble can feel really safe, and then it's scary to step down. And I would love to hear about that step down process and how we can make that a smooth transition.
Yeah, so I'll give the example of like, let's say we're stepping down from higher level of care, like IOP. Usually that's oftentimes the step that people will get to before they transition back to us here in outpatient. So that again can be a really scary thing because they're going back to real life. Maybe they're going back to school or work or the home environment that may not be the most supportive, or it might be a little bit triggering, even if everyone in the household is trying to be supportive. A lot of times that can be a little bit of a tough transition. And so I always like to connect with whoever the higher level of care providers were. So I love to read the physician notes and talk to a physician if I get the chance, or psychiatrist, therapist, definitely the dietitian. I'm always wanting to, start someone off, if possible, on the meal plan that they came out of higher level of care in, because they're most familiar with that. It's usually the most appropriate for them. And we may kind of iterate things as we go along. But that's one of the things I will do, is try to keep the meal plan the same. So whatever strategy, there's plate by plate, where we're just like kind of looking at the plate and how we break it down in terms of food groups. Some treatment centers use the exchange method, which is kind of like X number of servings of these different food groups. Here's how we spread it out throughout meals and snacks. And so kind of whatever they came out of with, I'm trained in all of those. And so we'll try to keep that as consistent as possible. And then usually when someone transitions out of higher level of care, we're meeting pretty frequently. Sometimes parents are surprised to hear that I might be meeting with a client once a week. And that's totally normal. We might even do a second session during the week that's more of like a meal support session. So we're not actually, discussing nutrition or discussing the eating disorder, but we're really just there to be a source of support during that meal, and kind of help them navigate whatever's coming up during that session. And so that's what that transition process looks like. We're definitely making sure we have a full care team if possible. So it can't just be me that's their outpatient team. There needs to be a therapist on board. That is a requirement I have for accepting someone out of higher level. And there definitely needs to be some medical monitoring, ideally by a primary care doctor or a pediatrician. And we will establish a cadence for how often we think that that's appropriate.
Yeah, you're bringing up a really important aspect of the step down process, of the transfer of or transition of care. And it is so important. We cannot just be blind receiving our client back to outpatient services. It is so invaluable, the information we can learn from speaking to that team. I'm somebody as well that I actually try to stay up to date with what's going on. So I actually like receiving periodic updates. I love it when treatment centers send a little like case update. But it's so important that we make that transition from, as Zoe referenced, the bubble into, I mean, their bubble's going to get popped day one. They might get picked up in a car and that Ozempic ad is on, and there we go. So I think a lot of people too don't realize that there's a lot of safety factors in a treatment setting. Like even the language you're allowed to use is monitored. So people are not really allowed, I hate to use that term, to say kind of triggering statements or the statements that are a part of diet culture, and you will be quote unquote redirected. And it's really good for the individual with the eating disorder, one, to monitor how much they're using that language, but two, what a safe environment to sit down at the table and nobody's allowed to say those things. So a lot of times what I say to people too is when they're like, well, what is this going to be like? I kind of say how you're feeling now. I said, look around and be able to relate to people and them saying sentences that you've said in your head, thinking it was you this whole time.
Mhm.
So that is kind of the beauty of it. And I think too, I tell people you eat, sleep, and breathe your eating disorder recovery. So all day long, yeah, we are in groups, we are in meals, we are in snacks, we are in processing groups, we're with our therapist. Um, but that sort of support is so invaluable that sometimes what I tell clients is you really struggled after dinner yesterday. How would that have felt to have a direct care staff at your table to process with you? And sometimes I try to give that information too, that this is not all bad, certainly not a punishment. But it's not all bad. Like if people are willing to use that supportive service, you have constant access to support and the amount of change that you can make with being able to process every meal where you might be reflecting on all your meals with me on a session on how they've gone. It can be so powerful.
Oh, absolutely. And I think one thing that's really jarring to folks coming out of higher level of care is they may have sort of been, because they maybe have internalized a lot of diet culture messaging when they've gotten a break from that, because again, it's not really allowed to be discussed. We're not seeing the Ozempic ads. When we step back into the real world, it can be really jarring and we can be seeing that diet culture messaging everywhere. And that can be really triggering when we haven't been exposed to that in that way for a little while.
I wish we had this conversation in reverse because I want us to end on a positive note. Because yes, there are so many benefits to going to higher level of care. There's that bubble, there's that community, there is the camaraderie of being around other people who truly get what you're going through. And a lot of people have bad experiences. And I wish that wasn't the case. And unfortunately, when people come back, while they may be medically like safe, mentally they're maybe in even a worse spot. So how do you support clients in sending them to the appropriate treatment center to make sure that it's a good fit to decrease that likelihood that they're going to have a bad experience?
Yeah, absolutely. I think about everything I know about the client, right? So anytime I do an initial assessment with a client, I'm asking everything about their life, like their hobbies, their interests, what matters to them, what their home environment is like. And so just kind of knowing the client will really help inform what type of treatment center I will send them to. Some have a more of like a faith-based focus, which can be really beneficial for some folks, whereas for someone else that would be completely inappropriate, right? So like that might be something I may consider. Also, what type of like meal planning structure they use, like whether it's like a plate by plate or an exchange method, depending on the client, that might kind of guide my decision making. And then just kind of knowing some of the providers. That's one of the benefits of getting to chat with these providers. So often I know my clients that benefit more from like sort of like a tell it to you straight type of approach versus like a very empathetic and understanding and kind of meet you where you are approach. And so that's one of the things that I will consider. And it's true. If you look at the reviews for any of these treatment centers, I would encourage you not to look at them, first of all, because everyone has different experiences and it might be completely unrelated to what you might experience as a patient in that higher level of care facility. And a lot of the negative reviews are folks, unfortunately, that are still very much stuck in their eating disorder. And because of how intensely that higher level of care will challenge that eating disorder, that can come off really negative to someone who's still very much stuck. And so I'm not saying that everyone who's had a bad experience with a higher level of care it's for that reason, but that is one of the reasons, and that's why you'll see very, negative and intense reviews online about these facilities often.
I'm glad you bring up the reviews thing because I would say I would identify that as one of the barriers I see in my practice of people going to a higher level of care. I'm like, here are a couple places that I think would be a good fit. Look into them, and they're like, did you see their ratings? And so I actually usually try to get ahead of that rather than problem solve. I try to prevent and I say, look, if you have a very good experience somewhere, why are you going to log on and do that? From a psychological perspective, our motivation to write something is much higher when we've had a negative experience. And so I do believe that those reviews are highly skewed. But I also tell people when I am referring to a higher level of care, I tell them straight up, I don't think this is going to be a perfect experience. I am not promising perfection. I'm not even promising a fantastic experience. What I am or not even promising, is that I'm hopeful of, is that you are receiving the level of support that you need, you are receiving more roundabout care, and that this is a positive influence on your recovery as a whole. The other thing I bring up, milieu matters. Who else is in that facility? I have seen people when they get referred to a higher level of care and they make really good friends and they're there with really like-minded individuals. That is just a monumental moment that people actually will miss that environment. And that's a whole nother podcast. But then if there are people that they just didn't really make strong connections, that's going to impact it. Even the staff milieu. There's a lot of times a high staff turnover. And so I might have sent somebody a year ago to this location and they had a wonderful experience. I sent someone there now, and now I realize, whoa, I don't know any of these staff, and it was different. And I think too, it is just every single person is going to be different. But I will say, I give the disclaimer that I am basically going to guarantee a lack of perfection. There's going to be something here that is not going to be highly helpful. And sometimes just leveling with that and acknowledging how these systems play out can be good as well.
And that honesty from the provider at the outpatient level can, one, prepare the client to be more successful at higher level of care. And then it also mitigates rupture when you do step down from a higher level of care, because you don't want your clients to feel blindsided by any experience. So that honesty is really going to set them up for success at all levels of care. But we have to start wrapping up. I want to ask Devin, do you have any last things that you want to share with our podcast listeners?
Oh my gosh. Well, the last thing I would say is that if you are getting the sense that maybe you're someone who could benefit from higher level care, or maybe you're completely terrified of the idea, but it's been brought to you, if you're feeling nervous or fearful about taking that next step, I would say that signing up for that initial assessment session is not signing your life away. It is really just getting more information and getting another opinion. And sometimes that can be really validating with that kind of like struggle to feel like you're sick enough. Having a licensed, trained professional giving you that recommendation can sometimes be that push that you need. So if you are someone who's in that situation, I would just encourage you to schedule the appointment, talk to your provider about, if they have a treatment center that they'd recommend for you, because that might be the thing that is, it feels like it's a disruption, but really it's what's going to accelerate your recovery in a really meaningful way. And so I would just take that, it's never going to feel like a perfect time. You're never going to feel 100% ready. There is no arrival point where you're like, okay, I'm ready for this now, but it is really a worthwhile experience.
Well, we will give one last shout out to our advertisers, Alsana. They have virtual options all over the country and then in-person options in California and Alabama. So thank you so much for joining us today, Devin. We are on the mic with Ed. Take a seat with us.